All right, we're gonna get started in about 30 seconds here. Okay, well, we'll go ahead and get started this afternoon here. Uh, Good evening, everybody. Thank you for joining us for another session of the Virtual Global Spine Conference. My name is Ali Baaj. I'm happy to be presenting today. This week, well, this month is actually very special, and for a lot of us here and on the host and faculty side, but also on our colleagues who have been following us. This month marks our 5-year anniversary, exactly 5-year anniversary when we launched this initiative during the pandemic. So it's very exciting to continue to be doing this, and it's an honor for me to be presenting today. We are going to discuss a topic very briefly in the next 20 to 30 minutes or so. We can spend hours on this, but I thought I would highlight a few key points regarding cervical spinal deformity surgery, including some principles and perhaps some pearls that some of our colleagues can take home with them. So without further to do, let me go ahead and get started. The first thing that I would say is this is my initial slide typically for dealing with cervical deformity. But honestly, if you can actually cut and paste this into thoracic spine, lumbar spine, because this principles more or less are the same. Understanding what the focal parameters are, understanding what the global parameters are, defining the releases and the resections, ensuring that you have proper fixation. And of course, often with deformity, it's not really motion preservation, it's in fact fusion, arthrodesis. So I would say those are the 4 or 5 principles really of any deformity surgery in the spine, but it certainly is quite pertinent to the cervical in particular. I'm going to talk about some of these parameters, which historically we have really measured off X-rays, but just to make it simple here, I'm showing it off this CAT scan, but I'll show X-rays as well. But in general, we're looking at things that a lot of us in spine surgery are used to, right? Like lumbar lordosis, the SVA, the plumb line, the K line. In addition, maybe here, what I would say, especially to my general neurosurgery colleagues, is we probably should spend a little bit more time on the T1 slope than we historically have, because that really affects our knowledge and our understanding of where that deformity is. And I'm going to talk about that. But this is a nice snapshot of, the 4 or 5 parameters that we want to measure and look at. Now, you can go to the literature and look, paper after paper about what that right number is and what's that magic number, if you will. And the reality is, just like in the lumbar spine, it's not necessarily a specific number, but it's really related to the patient's age, the patient's preoperative parameters, and we use that as a benchmark. But in general, you want that C2 to C7 SVA to be less than 4 centimeters. You want the patient to have lumbar lordosis, right? Not a straight neck or cervical kyphosis. So we want cervical lordosis. But there are some parameters out there, and they have these on cheat sheets or images that you can put in your pocket or quickly access it from your phone. Those are just general numbers. But the most important thing, and this is a patient who previously had a C1 down to C7, I think, fusion. They developed DJK or DJF, which we'll talk about. But it is important in really any deformity surgery when you're treating a deformity, I say don't extend the deformity. And again, this patient had a deformity, and all the surgeon did really is just lock the person in place and extend the deformity, which for various reasons may be right or may be wrong, right? It depends on the case. We don't, in an elderly, unhealthy patient with significant comorbidities, maybe we want to get in and out. But again, at least the concept here is the treatment of deformity is not extending the said deformity. Okay, so that's why it is important to sometimes get a better handle on these things. You can't really give a deformity talk and cervical spine without mentioning this very popular Ames classification, that a lot of us spine surgeons do, the ACDFs and the posterior releases, which is the grade 2 corpectomies, and then you get into a little bit more of the advanced techniques like the grade 4 to 6, if you will, once you have anterior osteotomies, posterior based osteotomies. So this is a really nice classification system that was published years ago now, over 10 years, but it's still very helpful. This is a little a shameless plug, if you will, into some of the work we did also years ago on simplifying some of those concepts into the deformity principles. So this is a nice review paper that simplifies some of these that you can access online. But basically, to understand the cervical deformity, the cervical spinal deformity, there are really three types of images that you have to look at. You got to make sure that the bone density is good and everything else. But when it comes to the actual decision making, after you ensure that the patient has good bone density and is optimized, you want to look at three things. You want to look at the MRI, the CT, and the X-rays, because each of those is going to give you, different information. The MRI is going to tell you where the stenosis is, where the compression is, and therefore it's going to dictate where the decompression needs to be. The CT is really important for deformity because it tells you where the ankylosis is, where's the prior fusion, where's the hardware, what does it look like? And it's going to dictate, therefore, the releases and the resections. And finally, and this is probably the most important imaging study, is the upright X-ray, or in the case of deformity, is really the standing, 36-inch X-ray, or the EOS X-ray, which is to tell you where the alignment is. And that's how you're going to measure preoperative deformity parameters and how you're going to gauge your correction. So the MRI, the CT, and the X-rays are going to tell you different things, and they're going to dictate where you're going to do your decompression, your releases and resections, and your correction. Very important concept here in this slide. So, this is a patient that had a cervical thoracic deformity. I'll show the X-rays later, but this is what a PCO looks like basically in the cervical spine, a complete osteotomy at multiple levels to really release the joints and ensure a proper deformity correction. Now you can do a 3-column osteotomy like a VCR or PSO. Certainly when we can, to limit the morbidity, we try to do, if it's effective, a 2-column or what's considered a PCO, posterior column osteotomy. So this patient, for example, who had a rigid kyphosis due to a prior infection that was not treated, and now we had to go front back with first a stage 1 anterior, then a stage 2 posterior cervical thoracic correction. And the patient did well as far as we followed them up for, I think, at least 2.5 years. Did not need a revision surgery. So again, the CT tells you where the ankylosis was, and then the CT and the MRI tell you where the releases need to be and the decompressions. So this patient did pretty well. Again, did we bring him back all the way to lordosis? No, we didn't. But do you want to bring somebody who's been in 50-degree kyphosis to lordosis? I'm not sure about that, right? You have to be careful with the stretch injury of the spinal cord. And so we're a little bit conservative, especially with the cervical spine in terms of the correction. And again, these are two additional, the top case is the case that I just showed you. The bottom one is more degenerative, where it was a little bit more rigid. So we felt again we had to do a front back surgery. I'm not a big fan of necessarily doing front back or back front back. It all depends on whether the spine is flexible. Is there a prior fusion? Of course, if we can avoid multi stages and multi-level, multi approaches, that's better, right? Less morbidity. But sometimes you do actually have to do more than less in the cervical spine. And for those of us that do both cervical and lumbar, most of us will agree that the patients with cervical spine do typically really well, and they tolerate, front back or back front back a lot better certainly than our lumbar degenerative deformity patients. So, don't let that kind of steer you away from being more aggressive if you need to be. Again, another shameless plug here for one of our more recent papers on drop head syndrome. Again, a type of cervical thoracic deformity, or an idiopathic, if you will, idiopathic chin on chest. These tend to be nice. They tend to be flexible deformities. And again, that's the image where you're seeing the PCOs at multi levels to release those. This is actually an area that I enjoy quite a bit. I've done a handful of cases now over the last few years. They tend to be partially flexible, not completely flexible. They typically, you can get a good correction with a posterior only approach. And really, the most common issue here is not the correction; it's the distal junctional failure because what is your LIV at the end of the day? Is it T3, T4, or is it down to T8 or T10? And you can't be blamed for going really long with these. Drop head syndrome tends to be a very debilitating condition for obvious reasons for patients. And the most frustrating thing is that there's typically no answers, no diagnosis. You send them to a neurologist, they do a bunch of tests, and nothing really comes out of it. You end up doing muscle biopsies, and once in a while you'll get a diagnosis of a neuromuscular condition. But a lot of times these are idiopathic and they're very debilitating. And yet, yes, you do have to try physical therapy and conservative management, but at some point, especially in younger patients, you don't want to wait too long because then the deformity becomes very rigid. Then you have no option except to do a back front back or a front back front. But in this case, and in a couple of other cases I've done, we were able to achieve acceptable correction posteriorly, but we didn't wait too long, maybe about 6 months of workup, physical therapy, repeat imaging. And if it's not better, excuse me, if it's not better, then we're going to pull the plug and just go ahead on pull the trigger, excuse me, and proceed with surgical intervention. Now, to be honest with you, cervical deformity comes in different shapes, sizes, and forms. This is one of my earlier cases in my career. It was your, run-of-the-mill two-level infection, discitis, osteomyelitis. And at first glance, this is really not a tough case, right? Probably a two-level corpectomy backed up, with posterior augmentation. And to be honest with you, well, not probably, I didn't do a good job in treating this patient. I said, well, let me first kind of go posterior, stabilize her, do the decompression. She was acutely, getting acutely weak. And then I would come in a delayed fashion for an anterior approach. This patient, of course, also had Parkinson's. She had head tremors, neck, head bobbling, and it was just a disaster. So I'm showing you my own complication here. I did a posterior, it was a C3 down to T2, I believe, fusion. And you can see the staples are still in. The patient failed so quickly and so miserably that in retrospect, I should have done anterior, posterior at the same time, go long. That's what I would have done today, but I ended up taking the patient back, and she had poor bone quality, and I did I took the hardware from the back and I did a front back. Went a little bit, extensive on her, but I had to because of her head bobbling, so I had to also incorporate the occiput. Again, when possible, I try not to engage the occiput. You don't want to do an OC fusion unless you absolutely have to. But again, it shows you what really the deformity can come in different shapes and forms. It's not just these, very, severe kyphoses or kyphoscoliosis. A bad trauma or a bad infection coupled with comorbidities like poor bone density, smoking, diabetes, etc., can be a disastrous deformity if not treated aggressively earlier. And that's really the take-home point here. When it comes to OC fusions, I'll just spend a couple of slides on this. OC fusion is something that I've done for many years for different pathologies. And so I still say that it's better not to do it if you don't have to, but when you do it, you've got to take certain parameters into consideration. And the most important one really is alignment, right? You don't want to fuse a patient in what we call bird watcher's gaze, looking up, or it used to be called reader's gaze. Now we call it text gaze because you're always looking down. And so alignment is very important in OC fusion surgery for proper postoperative airway and swallowing. So this is a case. This is a patient that actually had an OC fusion elsewhere, had a very difficult, she couldn't even get extubated, and it was just not a great situation. And you can see here that she was fused in flexion, and you can see the chin folds, right? You can see her tucked in. So we actually took her back, untucked her, and extended a little bit to get rid of that crease, get rid of that fold, and ensuring that she is not fused in kyphosis, not fused in kyphosis, or really flexion, if you will. So it's to avoid those issues. And let me see if this video will work here. I like to use the Mayfield for my OC fusions and really for all my cervicals, but you can see that even with just that knob of the Mayfield, you can really adjust the flexion and the extension. You don't have to do major maneuvers, but I really like to get rid of that chin fold there and make sure that the eyes are looking straight down as opposed to an angle, and that really does give you a proper alignment. So I've learned that over the years, and it's a great trick to minimizing the potential airway issues with the alignment in the OC fusion. So this is going to be a little bit on the shorter side. We just wanted to, highlight a few principles here. Number one is identify the points of releases and resections. You really need a CT to determine where those releases and resections need to be, but you need the X-ray and a standing X-ray to tell you where the proper alignment is, so you can pick your UIV and your LIV correctly. Just like in lumbar deformity, perhaps even more important in cervical and cervical thoracic junction deformity, you want to instrument long. These are not, cases where you can be a little bit cute and go short, and especially if the patient has poor bone quality, which they typically do, or they're elderly. In lumbar degenerative deformity, we worry so much about PJK and PJF. In the cervical spine, because the C2 vertebra is typically so robust, we almost always, are okay at the UIV. C2 tends to be very robust. It's really distally where we get into trouble, especially with a high T1 tilt, right? I mentioned that in the beginning. Who cares about T1 tilt? Well, T1 tilt tells you, at least for me, the way I understand it and the way I have been implementing it in my practice, is the T1 tilt really tells me how far down I need to go. If it's a low T1 tilt, I may be okay stopping at T2 or T4. If it's a very high T1 tilt, then I'm really taking a good look at that thoracic apex and, needing potentially to go down to T8 or T10. Luckily, I rarely have to do that, but that's the concept here. So DJK, DJF is the problem with cervical deformity. It's rarely PJK and PJF, unless you're starting at C3, which I never recommend. If cervical or cervical thoracic deformity, just go save yourself the headache and the patient the revision and go to C2 from the get-go. And one of our outstanding fellows from 2 years ago published on this, which is the rate of proximal failure when you stop at C2 and C3 is quite different. You really want to go to C2 as far as the top. And then the last point here is fix early before the deformity becomes rigid. Obviously you got a young patient, you got an unknown diagnosis, like in these drop head cases, you want to do the appropriate workup. You want to give the neurologist a chance to, perhaps do some additional testing and, give physical therapy a chance. But the reality is if you wait too long, it potentially could be it potentially could be a problem because the deformity could be rigid. So whereas, you took a case that can be done all anterior or perhaps all posterior, now you're taking a case where it's more rigid and you're having to do a front back or a back front. So, my recommendation in the cervical and cervical thoracic deformity is, in the lumbar spine, I'm probably more conservative, and I do it a little bit longer with PT and pain management, et cetera. In the cervical spine, I'm a little bit more aggressive, and we try to treat them early, primarily because often they're presenting with myelopathy, and we shouldn't wait anyways. But when there is a deformity, it's probably better to treat it more rapidly and more expeditiously. So I just want to share those a few concepts. Again, I promised this wouldn't be long. It's already late in the East Coast, and I'm a lot later east of the Atlantic. So thanks everyone for joining us. And again, we're very happy. This month marks the 5-year anniversary of this program, and we'll have some we'll write about that a little bit online, and we will see everybody next week. I hope you all took a few take-home points from this talk, and have a great evening.